So this is the ECG of an elderly female which shows left anterior fascicular block. So you can look around it. So before I tell you the findings in the ECG, I'll share an important concept with you. So this is the vector diagram of axis of the electrical current in the heart. So as you can see, the various types of leads which I have drawn here. So as you know that the vector sum. So consider this as the anterior fascicle of the left bundle branch, this as the posterior fascicle, and this is the right bundle branch. So the vector sum of these three vectors falls somewhere around here, which equates to lead 2. So the whole current is targeted towards the lead 2. But now think of a situation when the anterior fascicle is blocked. So I'll just cut it. This is blocked. So what will happen is, because the intensity of the vector here decreases, the total vector sum will now shift towards. So I'll draw this with the yellow. Shift towards the posterior fascicle, somewhere around here. So what has happened is, because of the decrease in the intensity of vector, the vector sum shifts towards the posterior fascicle to fall somewhere in between them. So similarly, the in this diagram, if I draw the same vector after the blockage of anterior fascicle, it will be somewhere around here, which is now directed towards AVL and V6. So now we can clearly see that the axis is shifted from this second lead towards AVL, and this is basically a left axis deviation, as you can see. So the normal axis is somewhat around here, and now this the final vector is shifted towards a axis deviation side. So we can clearly see that the intensity of the R wave will decrease in the lead 2 and lead 3 and V2, V3, all these leads, and will increase in intensity in AVL and V6 and V5 and one lead. So now things become very easy. So now look at the ECG again. Normally what we see is the R wave is bigger in the lead 2, but here in this ECG, as you can clearly see, the R wave is small and the S wave is large. And in AVL, we are seeing, I'll just make it a bit large and you'll be see better. So you can see now in the AVL, the R wave amplitude is very big as compared to what we see normally. This is because the axis is now targeted towards AVL. And look in lead 2 and lead 3 and AVF, in all these leads the amplitude of R wave is decreased. So there is a less axis deviation, and small r and big S pattern in lead 2 and small q and big R pattern in AVL. So this is quite characteristic of left anterior fascicular block. And another very important finding is, just look at the QRS interval. You can see that QRS interval is increased, although it is still less than 0.12, but it kind of approaches that limit. So it is not a complete bundle branch block, because in complete block the QRS interval increases to greater than 0.12, but here it is somewhere around 0.12 and a bit less. So this is an indication of incomplete bundle branch block, and given the left axis deviation, this clearly points towards left anterior fascicular block.